Thank you. So over the past few months, I've been reviewing published literature in books and catalogs and databases to kind of figure out why these global organizations are still having a hard time eradicating malaria in sub-Saharan Africa. And this is sub-Saharan Africa, the biggest portion of Africa. As you can see, that's a big danger to Africa. Malaria is a parasitic disease transmitted by the female Anopheles mosquito, and it's endemic in sub-Saharan Africa because the tropical climate there favors the breeding of the Anopheles mosquito that actually carries the most deadly of the Plasmodium species called the Plasmodium falciparum. And unfortunately, the infants are the most fatal cases in this area. In 2013, the World Malaria Report indicates that 437,000 children died as a result of malaria. But this is a preventable and curable disease in 90% of the cases. Global efforts to eradicate malaria started in 1955, and malaria is the first human disease to be scheduled for global eradication. Those first efforts faced so many challenges, and as we will see later on in the presentation, those are the same challenges facing some of these new efforts to eradicate malaria. But these efforts have had some progress, and 1 million lives have been saved as a result. So these are the big power players in malaria. Bill and Melinda Gates have, as of 2013, provided $2 billion in trying to combat malaria. The World Bank has spent $1 trillion. The Global Fund is the largest single source funding for malaria, and it spent $8 billion in trying to eradicate malaria. The World Health Organization spearheads all international health activities. Now, the Rollback Malaria Partnership is the global framework that implements action against every activity of malaria. Now, I'm going to show you this. This is the international funding, the past and projected. At the turn of the millennium, with the funding from Bill Gates, they pushed and had a goal to halt malaria by 2015 and reverse the incidence of malaria. And as you can see, funding has been very effective until 2015. That goal has been met now, and we want to see what else is going to happen. They've been able to sponsor malaria to a place where now it's being reversed. What does this money do when it comes to sub-Saharan Africa? It develops vaccines. Well, I forgot to mention that even United Nations, UNDP, all those people are part of the global efforts to eradicate malaria. Vaccine development, there are over 63 groups of different researchers working on different stages of vaccine development for malaria. And for research, they use demographic health surveillance systems that track malaria progress. These are long-term projects that they put in all endemic countries. They also supply drugs because these are poor countries, they can't afford to do it. And they also respond to every epidemic. They supply free insecticide-treated nets to keep the vector away, which transmits the disease, and also have vector control sprays. They strengthen also health infrastructures through building healthcare centers, training healthcare workers, and actually providing the diagnostic equipment. But these efforts have been met with challenges. Now, because of time, I can't discuss all of them. I'm just going to discuss the two that I thought that you all should know about, and these may be the reasons why this is still a hard goal to achieve. The number one is a parasite that causes malaria. That is the Plasmodium falciparum. This is a very deadly parasite. It's complex. It has a very complex life cycle. It has defeated every scientist out there. That's the small parasite right there. It can never cause the same kind of malaria in human beings. Everyone gets a different strain of malaria. That's why there is uncomplicated malaria and complicated malaria. Another thing is it lives in the cells, so it's away from the immune response, which explains why vaccine initiatives have been going on for malaria since 1910, and they don't have. The most promising they have right now is the RTS-SS01, which is in actually human trials in 7 countries in sub-Saharan Africa. Unfortunately, the children being tested are like 6 to 12 weeks and 5 to 12 months. And those children are actually not surviving this. They are still dying, and you can't use the vaccine on its own. You have to use it in addition to the malaria preventive measures. On top of that, every child who's received this vaccine trial is getting seizures. So that is not a promising, as we can see. Also, the vector is the reason there is transmission. The mosquito is the reason there is transmission. And the vector that really hosts the parasite is also becoming so aggressive to the chemicals. Now, this is one of the challenges that happened back in 1955. The DDT spray that had been made, that had been created to help stop the vector that they would spray on the breeding pools, stopped working. And so because there was an emergence of very aggressive insecticide, now that's happening again right now. The parasite chemicals that were created to keep the mosquito at bay are no longer working. These mosquitoes have become stronger than it, which speaks of the parasite that they're carrying. It may be co-evolving with humans over time to beat up with the interventions they are setting up. Another one is that these are the long-lasting insecticide nets that were created. Now, global efforts have to provide these to these communities because they are poor. Unfortunately, they don't have enough money anymore because funding is going down. Just in 2012, there was 145 million, but by 2013, there was 66 million. And there is wear and tear. They have not supplied 278 million homes do not have a single insecticide-treated net. But even before they finish that, wear and tear happens. Another big challenge under Plasmodium falciparum is the emergence of drug-resistant parasites. Now, in 1955, they had chloroquine. Chloroquine was cheap, it was everywhere. It was able to treat malaria. But unfortunately, there was an emergence of mosquitoes. Now they treat malaria with a combination of drugs, the artemisinin combination therapy treatment. Why they do that is because to avoid the same problems that happened with chloroquine. To use it alone, they have to confuse the parasite and delay the drug resistance problem from happening. The World Health Organization has gone one step further and created the global plan for artemisinin resistance containment to try and keep countries tracking down resistance, because once resistance happens, transmission goes back up, and that's a big problem for global efforts. So the number 2 challenge is emerging and reemerging diseases. We also Ebola, we just heard about Ebola. But Ebola has been in sub-Saharan Africa since 1976. Unfortunately, it's a tropical disease too. So this is the community it attacks. And when it comes, all malaria control programs had to be put on the side for every effort to go towards Ebola to contain it, because as you know, it was deadly at the time. Another disease that they don't tell you about is malnutrition. When the rain comes, drought, the mosquitoes come and cause malaria. But when the sun comes out, the drought comes. Most Africans depend on the land for food. Now, when that happens, children are starving. Global organizations have to make these decisions every day to divert the money from malaria and take it to things like feeding the children, which are vital. Another disease, which is as old as mankind, is tuberculosis. These are the big 3 killers: malaria, HIV, and tuberculosis. Every time tuberculosis is fatal, and when it comes, everything else has to stop again because it's more fatal than every other disease, even malaria at its worst. Another one that I talked about was the concurrent management of HIV and in malaria. Unfortunately for sub-Saharan Africa, that's where the biggest, HIV is more prevalent there than anywhere else. There are over 23 million people living with HIV in sub-Saharan Africa. Now, the problem is global organizations didn't create drugs for these people. They have to still take the artemisinin combination therapy and the retroviral therapy for treatment. But there's no research out there to show if they are medically compatible in the body. So they have to go back to the drawing board and try to find medication for these 2 conditions because they're very prevalent in sub-Saharan Africa. Now, the other big problem that global organizations will face, or the major crisis, is sometimes all these situations could overlap in one place, and they have to divert the funds depending on what they're doing. So in conclusion, I thought that funding should not wither. It has been strong, it has been going on, and I know they've met their goal. They've reduced malaria to 34% in sub-Saharan Africa, but the goal was eradication, and we still want to see that goal. Funding will lead to vaccines. Vaccine is the key public health tool out there. We all don't hear about smallpox anymore, or measles, or polio, because there's a vaccine. So a malaria vaccine at whatever cost is needed. There are also several specific interventions for each group, like something for the children, for malaria, and something for the pregnant women and those middle people. And now they have to find something to concurrently manage HIV and malaria. That is too much, and it's not cost effective. And as we see the financial crisis is coming around the world, definitely money will be a problem in the future. So coming up with a more universal intervention is better than having this, but all that will depend on the funding. Another problem, another recommendation was endemic countries have not been held accountable. They're not providing data to these organizations. I didn't talk about the other 18 challenges I found, but one of them was data. They're not providing data. They're not giving progress reports to these global organizations. They can't keep up. And that's not fair because organizations have been doing everything. So more cooperation between them will be important in getting these organizations, getting some results. Even the cooperation between the endemic countries themselves, they don't have cooperation. There's so much political strife, and that is causing a challenge for global organizations to keep them on track. Another thing is the dependency syndrome in sub-Saharan Africa is huge. People wait for others to provide. Yes, the global organizations have done a great job in helping, but they should be empowering these communities to find simple tools. For example, it's the rain that brings the local breeding pools, but these are very small holes and they're very temporary. These are the lava sources. If they could only find out that this is where the lava source is and help themselves, maybe they won't need these indoor residue sprays or outdoor residue sprays, and they can get rid of these themselves. But they need to be empowered. Last but not least, the global organizations have done a great job. They have achieved what they set out to do. Every few years they've set out to do, their target goals are being made. I told you that in 2015, they targeted to halt malaria and to start reverse its incidence, and they've done this exactly, they've made that progress. But the problem is there's no need for more interventions. There is enough. They just have to be improved. Unfortunately, they're not being evaluated because of the big problem. There are over 41 countries, endemic countries in sub-Saharan Africa. They don't evaluate their programs and they don't improve. So there's need to improve those existing interventions. What's working in the low transmission areas? What's not working in the low transmission areas? These questions are important. But thinking about all these think tanks, I'm not thinking about anybody else but us as students. Healthcare students, we can help and get involved in the fight against malaria. We can be the change we want to see in sub-Saharan Africa. Maybe we can design evaluation programs. Nursing students, you can work on those Plasmodium species. It's your area of expertise. You be the people you want to see, but there is need for us to get involved. Let's not wait for Cato Institute or these other think tanks to come in and do the work for us. Let's be part of the change we want to see. And maybe together we will be able to contribute to the eradication of malaria in sub-Saharan Africa. Thank you.
The floor is open for questions.
Yes.
The parasite you talk about,
Yes.
you said has all different forms.
Yes.
Is it because it mutated, or there are all different types of malaria?
So it's a very complex life cycle. It has a very complex life cycle, and it's a very complicated parasite. As much as they know it, they don't even know if it's mutating. The scientists are still working on realizing, is it mutating because it keeps coming out. But they think that because it's been around for a long time, it has started to co-evolve with human beings. So maybe mutation is happening, but somebody needs to figure out exactly what's happening. So there are more studies needed to figure out this parasite in the life cycle of the parasite. But it's also hard to track because it lives in the cells. So, yeah. Yes? Thank you.
So, what do you think is the biggest, I guess, I'd say, difficulty in creating some sort of health infrastructure in sub-Saharan Africa? Like, why aren't people going back and helping? Now that the money is there, why can't they have something in place?
I think it's governments. Sub-Saharan Africa seems to have leaders who act like kings. They don't want to leave power, and when any funding, anything that goes through them, they decide what they do. Now, global organizations are not enforcing that. They don't try. Because they want to help the people, they don't try to go against these countries. So the biggest problem these countries have, and why some public health is failing, is because of the governments. If the president is not on board, then everybody else can do it, and they have to work within those limits. Yes?
I think it's interesting that, like, with the Ebola outbreak,
Yes.
our President Obama was very vocal and trying to make things happen.
Yes.
And you don't hear that necessarily with the malaria or some of these other diseases, which seems unfortunate because
Yeah.
it seems to really, I don't know, maybe this is just my perception, but it seems to get those countries moving or a little bit more invested.
I think that's what I didn't mention. There is a presidential malaria initiative in place. There's so many funders, but I mentioned the big powers. Now, when people are giving billions, I think that's what I was basing for, but there's so many funders, and the president of America, there's a presidential malaria initiative in place, and USAID, they all offer money. Just in 2013, they offered $584 million US to combat malaria. So they're part of the struggle. It's just that their efforts are almost put on the side because now we have Ebola up. Malaria is almost a forgotten case. Yes. Yes.
So, talking about empowering community, would you see programs being put in place for empowerment and staying with those programs over a longer period of time and having presence within these countries for a longer period of time to work on empowerment programming?
I think utilizing the resources in the country through public health. Now, I feel like public health, I don't think these countries have enough public health because it has failed them. Using the resources in the country. I've said this before, that you can't go into a country where you don't speak the language and try to enforce something. It's almost like a diffusion of innovation. You have to use the people who live there. Maybe lay health workers, train somebody to go do the job, but not be the one. I mean, global organizations can provide the money and supervise the work over time, maybe come back to evaluate what is happening. Has something improved? Has the progress, but without progress reports, without accurate data, you can't even know what you've done so far. So it all goes back to, first getting the endemic countries to get on board and be part of this solution, and then getting them to say, hey, improve your public health. Your public health could empower your communities to do something. Yes. Yes.
I agree with what you were saying related to the education piece.
Yes.
So I do training and development, instructional design work, and I noticed that a lot of these global consulting, healthcare consulting firms were like advertising for when Ebola, it was like Ebola educator, Ebola trainer, Ebola, and I think that largely that's something that's missing in terms of being able to educate and empower, and that's, I think, is a large part of empowerment, is education. And so when a culture or a group of like-minded people receive education on something that is impactful to them, I think you see change, you see that empowerment and motivation. And I think that that's something that largely the government inhibits sometimes, which causes these epidemics.
And that's true. And maybe to add to that, malaria has been around for so long. It's, like I said, it was the first human disease to be scheduled for global eradication. People assume everything is going well, but the reality is, if a child is dying every 60 seconds that you've been sitting here, that is still a big challenge. But you can't hear about it when you hear about these other challenges around, like Ebola. So, yeah.
Okay.
Thank you.
Thank you.